How about that?
Yes, perfect.
So just to give a little context before we dive into the project, like Ahmed said, according to the WHO, 50% of all deaths around the world have no cause of death assignment, and 90% of those exist in the low middle income countries. And when it comes to maternal deaths, over half of maternal mortalities happen in sub-Saharan Africa. And when we talk about Somalia in particular, a country that has been affected by 3 decades of civil war and suffering from several gaps in the infrastructure of the healthcare system in the country, the maternal mortality ratio is 692 per 100,000 live birth, according to the Demographic Health Survey 2021. The system in Somalia has significant gaps in the mortality registration in general, and the maternal mortality registration in particular. And especially the registration varies between rural and urban areas. So there is disparities in vital statistic representation between rural and urban areas in the country. So the way we work, as we said, that we collaborate with the ministries of health and non-governmental organizations in the countries we're aiming to work at. And in Somalia, we collaborated with the Somali Institute for Health Research, which is a very reputable organization that did many researches and public health interventions in Somalia. And they have several collaborations with the Ministry of Health, which is very important for us to ensure the sustainability of our project. So once the collaboration is done, we have several discussions to agree on the specifics, as we say, of the project. So we agreed about the place where we are going to conduct the project, and we agreed on Galakayo, which is a major town in Puntland in Somalia. We agreed to conduct 50 cases as our sample size that was identified through hospital records as well as through community leaders, just to have representation from both deaths that happen within and outside the hospital setting. We selected it through purpose of sampling, and the timeline of the project was 6 months. Once we identified the major headlines of the project, we talked about the human resources and other resources required for the project. But when it comes to human resources specifically, our partner was responsible to provide the people who were going to conduct and supervise the project on the ground. And that included a project manager who were going to provide oversight for the project, supervisors who were going to monitor the survey process, and 5 female community health workers who acted as interviewers for the project. Once we identified the human resources, we started to provide them with the training. So the training we provided included several topics. It included what is VA, the history of verbal autopsy, what is civil registry and vital statistics system. It included public health ethics, sensitivity training on how to conduct the survey in the most compassionate manner. Some of the challenges that they might encounter during the survey process, and of course, training about the questions itself within the survey and how to conduct the survey and administer it. We provide this training to the supervisors, who in turn are tasked to provide this training in their own language to the community health workers, just to make sure that they're comfortable enough with the survey and they know how to administer it without any difficulties. The last stage of the training included a field practice where they actually went to a real death cases and they interviewed the households just to make sure that there are no any more challenges or training needs. So once the training is done and we make sure that everything's settled, we start to conduct the interviews, or what we call the data collection process. And through the data collection process, once we identify the death case and the household, the supervisors will map out the interviews, and the community health workers will head to the household to obtain consent and get the survey. Once they get all the data within the survey, they will write it down, upload it to the server where we will receive it, just review it to make sure that there are no any discrepancies, there are no any missing information. There are a lot of quality checks that that takes place just to make sure that the information that we collect is of optimum quality. So once we're done with conducting the interviews, we identify the cause of death assignment for each survey from through generative AI, through our collaboration with Dr. Abraham Flaxman. And then once we have the cause of death assignment, along with the other data that we collected on the ground, we conduct the data analysis and we provide a comprehensive report for our partner with the analysis that we conducted, along with some recommendations for public health interventions according to evidence. So I will share with you some of the results of the data that we analyzed. So when it comes to the cause of death data, almost half of the our sample size died due to hemorrhage. It followed by sepsis and eclampsia. When it comes to the death location, 22 of our sample died in the hospital, and those were the cases that actually were identified from the hospital records. 13 died at home, and 11 cases died en route to the hospital or facility. This is an analysis of some of the comorbidities that were reported by our respondents, and 13 of our sample reported blood pressure as a comorbidity, and this was followed by diabetes, asthma, kidney disease, and stroke. So as we talk today, there is an open narrative section within the survey. Through this project, we use the 2022 WHO Verbal Autopsy Survey, and there's an open narrative section, like we said, that the interviewer has to write what the interviewee is saying in their own language or in their own words. Through the analysis of the open narrative section, we were able to gain insights about the health systems or social factors that might have contributed to these deaths. And some of the insights include barriers to accessing timely medical care. And this is such as reaching health facilities due to distance, lack of transportation, and refusal or reluctance to seek medical attention despite experiencing complications. And this is really resonates with the 11 cases that died en route to the hospital. We also found limited access to antenatal care and postnatal monitoring, and this was reported and evident in several cases. Antenatal care and postnatal is very important to identify possible complications, educate the future mothers on when to seek care, what to do. Several educational activities happen during that, as well as monitoring for any possible complications, especially after birth, where complications can happen up to several months following the delivery. Limited community awareness and educational programs. The lack of awareness and misinformation was actually influencing decision-making regarding health-seeking behavior within the sample or within the respondents that we interviewed. So throughout the project, we encountered several challenges. Some of them were political, some of them were related to climate changes, floods, some of them were related to language barriers, but I listed here some of the challenges, the most frequent challenges that we encountered. The first one was that there was difficulty in identifying death cases through the hospital records, and that was due to inadequate documentation within the medical records, or due to many crucial documents lost as a result of manual record keeping process. The second frequent challenge was that some of the questions that was within the survey was culturally sensitive in the Somali context. An example of that was the questions related to HIV and AIDS. there is some kind of stigma and like shyness when it comes to answering questions related to HIV and AIDS in Somalia. So respondents were often reluctant to answer these questions due to maybe shyness or due to insensitivity of the question in the culture. And that was the case specifically when the respondents was of opposite sex. The other frequent challenge that we encountered was that some respondents found it unusual that the interviewers were gathering data on death cases, and they were kind of skeptical. Even though we tried our best to employ the solutions that actually worked with us before on how to make the society trust us more, but some households were still skeptical. So it needed like a good time for us to fully explain the project, fully explain the purpose of the data collection, that the data will at the end is going to end up with the Ministry of Health, and we will try our best to do whatever that will benefit the society at the end of the project. So Ahmed touched on this. I'm just gonna walk you through it. This is when it comes to the next step. So we finished the first step in our maternal mortality project in Somalia. Now we are moving to the second stage with the 500 interviews, and it will include 2 more rural areas in the country. So now we're raising funds for this second stage. Outside of Somalia, now we are in the initial phase of our project to identify causes of death in the Rohingya refugee camps in Bangladesh. And we're also raising funds and identifying partners to conduct a mortality surveillance project in the rural areas of Nepal. So this was all for me. I'm just gonna part with you with one quote from one of the respondents that we received when he said, "This is the first time anyone has come to listen to us and to understand what we are going through." Thank you.